This is our web talk sponsored by the Integrated Substance Abuse Treatment Programs. And today we have the honor to have Dr. Hector Rodriguez from University of California, Berkeley. He's the Henry Kaiser Endowed Chair in Organized Health Systems, Professor of the Division of Health Policy and Management, Chair of the PhD Program in Health Policy, and Co-Director of the Center for Healthcare Organizational and Innovation Research, CHOIR. So he keeps pretty busy. So we are honored to have him here today. And the structure of the web talk will have about 10 to 15 minutes presentation, followed by kind of a quick and intense round of Q&A with a purpose to kind of get these conversations going. So without further ado, Hector.
Thank you.
Welcome.
Hi, everyone. Eric, kind introduction. I'm pleased to share this work with you, which has been the culmination of a 3-year project funded by the Patient-Centered Outcomes Research Institute focused on patient engagement and exactly what practices within accountable care organizations are doing to engage patients in their own care and the extent to which those activities are linked to patient-reported outcomes of social, physical, and emotional function. We're interested, and we focus mostly on patients with diabetes and or cardiovascular disease. Many of these patients, about a third of them, have comorbid depression or mental health issues, which may have a lot of significance for the work that you do. So while I'm not going to be talking specifically about substance abuse, a lot of the patient engagement strategies may apply to the settings that you're in study. So we were also, secondary issue that brought us to this research is the role of teams and their relationships with one another and the extent to which those support patient engagement. And if so, how do they go about supporting patient engagement team members? So I wanted to acknowledge my co-authors in this work and wanted to thank PCORI for the funding of this work. So as I mentioned, ACOs, which are new delivery systems stimulated by the Affordable Care Act, which they require a defined population of patients. And that defined population, the organization is accountable for the total cost of care for that population. And so it really has created these incentives for patient engagement because the contracts are now risk-based, which means that they either have global payment in which if they spend more, they have to eat those costs, or if they don't achieve performance targets, then they won't get rewarded or sometimes will get penalized as a result of those. Currently, most ACO contracts aren't double-sided in terms of penalties as well as in bonuses. They're mostly bonuses at this point. But in the future, incentives may be more balanced in terms of the risks, in terms of having downside risk and penalties. So everybody's curious about how to avoid these penalties through engaging patients with chronic disease in their own care. And so the ability of these ACOs to succeed under these new payment models of total cost containment depends on improving the implementation of strategies to engage patients in their own care. But there's been little research as to exactly what this means in primary care settings. And we know from previous literature that team-based care and those relationships, that foundation of relationships, creates a foundation potentially for improving patient-reported outcomes, things that patients care about. Social function, physical team members actually supports the patient engagement process. So we wanted to look at a 1-year time period in terms of before and after the implementation of feedback to the practices with respect to these measures of physical, emotional, social function. And we sampled diabetic and cardiovascular disease patients in 8 practices, 8 that had really high adoption of patient activation and engagement strategies, and 8 that had very low or very limited adoption of patient activation and engagement strategies. And to contrast what their patient-reported outcomes were, patient activation, how the team process differed between these two populations of practices. And then we did some qualitative work to understand exactly the mechanisms by which relational coordination helps the patient engagement process. So our study hypothesis, we really had three going into this. The first one was that, consistent with other literature, we expected that more highly activated patients, as measured by the patient activation measure, which is a measure, a well-validated measure of self-efficacy for chronic disease management. We thought that those patients who had higher self-efficacy or patient activation would have report better physical, emotional, and social function compared to less activated patients. We also thought that patients of practices that used a lot of these patient engagement strategies the patients would be more activated and have better patient-reported outcomes and improved outcomes, patient-reported outcomes over time, compared to practices that did very little in terms of engaging patients. Our third hypothesis is similar to the second in that we expected that practices with high relational coordination or high trust and respect and good communication among team members would have better patient-reported outcomes of physical, emotional, social functioning, and that they'd be more likely to improve these PROs over time compared to patients that are part of practices that have relatively lower relational coordination. And so our samples were really, we had two accountable care organizations, one in Chicago, greater Chicago area, one in the greater Los Angeles area. We took 71 of their practices and sampled and did baseline surveys of what they're doing with respect to engaging patients. Then with that distribution in each ACO, we took 4 practices in the bottom quartile and 4 in the top, resulting in 8 in the high and 8 in the low group. And we did measurements at 2 points in time. We also conducted to assess relational coordination and clinician and staff surveys at the 2 points in time as well. And we achieved really good response rates in the mid 80 percentiles for those. And our sample of patients from these practices of the ACOs were 2,176 patients were sampled in time 1. And then in time 2, there were 1,276 respondents. So actually, these 2 are the respondents. The outgoing sample was much larger, around 3,500. And we took, once we had the survey from these patients, we took clinical and administrative data for these patients and non-respondents to integrate with the patient survey data to get a sense of how patient-reported outcomes and clinical outcomes for these patients actually related. Our primary measures for this study were high or low patient activation at the practice level. And just to give you a sense, the patient activation assessment included assessments of the extent to which the practice was engaged in motivational interviewing, which has its roots in mental health and psychology. Shared decision-making for diabetes and cardiovascular disease, shared medical appointments, health risk assessments and routine use of those, and including patients in the quality improvement process, allowing patients to see the dirty laundry, in other words, of quality improvement in clinic governance and contributing to those efforts. In terms of our team survey, we used the well-validated relational coordination measure, and for patient reported outcomes, we used the well-validated PROMIS measures for social and physical functioning, and the PHQ-4 for emotional function. For patient activation, we used the 13-item patient activation measure, which is well-validated in the literature. For statistical analysis, this is just to give you the formula of what we did when we looked at differences between practices. So we used a multi-level model, which essentially predicted the patient-reported outcome of physical, emotional, or social function. And the coefficient that we're controlling for all these characteristics, what was the relationship between patient activation and engagement at the practice level, which is B1. But we were really interested in the interaction between having high or low patient activation at the practice level and overtime changes. So we're really interested in beta 3 and in beta 8 for our hypothesis 1, which is really about patient activation. And so B3, for hypothesis 3, we just replaced relational coordination for PAE. They can't be assessed simultaneously because of collinearity and those issues. And we also, to supplement these quantitative analysis, we did 103 one-hour interviews with clinicians, staff, and practice managers from these 16 ACO-affiliated practices. And these were generally in-person interviews where the study team went out to the sites for a week. and hit all of the practices within the ACO. We use iterative coding by 2 separate coders and Atlas TI to contrast the team processes as described by low versus high practices. So we kind of looked at the content of those interviews and kind of contrasted them. To give you a sense of what these practices adopted in terms of the results, as you could see, the high and low practices really differ with respect to the main patient engagement strategies that are most common. So the most common patient activation and engagement strategy for diabetic and CVD patients is at-home monitoring devices, use of blood pressure monitors, use of glucose monitors and the like. And of the high practices, 8 of those practices of the 8 were doing it, and only 4 of the 8 of the low were doing that. I wanted to highlight a couple of ones that stick out in terms of differential adoption between high versus low. One is motivational interviewing training for clinicians. To have that support system and training available and promoted to the clinicians was available in all of the high practices, but only 2 of the low practices. Programs specifically for medication management follow-up, generally with pharmacists, were available in 8 of the 8 practices, only 2 of the low practices. Importantly, family participation in programs, adult patients, adult children are really important in many cases for supporting their family members in managing diabetes. And 7 of the 8 high practices had those programs in place, whereas only 2 of the low practices did. Another notable difference is health coaches. 6 of the high practices had the health coaches embedded in the practice, where only 2 in the low practices had them. So there are several other patient engagement strategies. There's actually 39 in this instrument, but this is just displaying what are the most common and how the high and low differ. In terms of the patients in this population, it was a commercially insured primarily samples with some Medicaid and Medicare patients. But as you could see, when we look at the compare patients in high versus low practices, one significant difference is that practices that use a lot of these engagement strategies tend to have more African-American patients, and they tend to have comparable numbers of Latino patients, but fewer Caucasian and white patients. Whereas low PA&A practices, those that have very little investment in this area, tend to have more white patients than Black patients. And these are the markets are Chicago and Los Angeles. In terms of patients by age, as you can see, there's very common distribution between high and low, and we have a really big sample of those 65 and older in this population. When we were interested in looking at relational coordination, this team survey that we did, we were interested in, does the high practices, do they get better in terms of the relationships, given that they're doing all of this patient engagement? Does that help their relational coordination? Does that foster more of it? And we see that that's the case in this. I don't have the significant, it's actually a marginally significant at 0.05 effect of the high practices improving relational coordination over time, whereas the low PA practices held steady. And these differences are significant in adjusted analysis. In terms of addressing our first hypothesis, it was clear that if patients reported that they were highly activated, had lots of self-efficacy, their measures of social, emotional, and physical function were much better, highly significant. In particular, their social interactions and ability to participate in social activities with family and friends and the like. Importantly, we find no difference in patient-reported outcomes for practices with high and low adoption of patient activation. As you can see in the overall graph on the left, we have very steady means across both samples over time. So in the blue bar, you could see physical functioning staying pretty steady, emotional functioning staying exactly the same, mean estimate, and social functioning staying pretty steady. And as we look across, there's no real differential shift between high and low in terms of these patterns. Remarkably, they're very stable. It says a lot about the validity and reliability of these assessments, but it also is sobering in terms of organizational change. In terms of relational coordination, when we stratified the practices based on their relational coordination instead of their patient engagement strategies used, we found the same pattern. no significant changes between high practices that did a lot and practices that had high relational coordination and those that had relatively low relational coordination. Our key informant interviews really shed light on some of these findings. We found that in high practice patient engagement practices, key informants really had different conceptualizations of their team membership boundaries, while informants in the low engagement practices had really scattered and loose and fuzzy boundaries of their teammates. And I think that part of the good teamwork is this idea of knowing who's on and off the team and to manage those boundaries and relationships. And so I think part of the story with relational coordination is that patient activation actually stimulates the need, working on patient activation stimulates the need to coordinate these relationships and make them better and to define team boundaries and the like. There was really differences in the scope of responsibility that people saw for patient engagement. In these high practices that did a lot, they described lots of challenges working with patients to address social needs, but this was only mentioned once proactively in the low PA sites, indicating that they're not really systematically addressing social needs in these practices that have lower patient engagement. And it might be because there's less need for those kinds of support systems. Low patient engagement, everybody said patients are the problem in terms of low engagement. It's not really our responsibility. There's a lot of responsibility on the patient. However, this tended to happen more in low practices. Those that had less experience with engaging patients tend to blame the patient more for low engagement rather than kind of attributing it to the system and what can we do to improve engagement for patients. Everybody described resource barriers and time and constraints and barriers, but these sites that did a lot had experiences of overcoming implementation challenges. And so in the patient-centered medical home literature, there's a big thesis that a lot of the success and failure of these initiatives is based on motivation and commitment to the change. And these obstacles are an expected part of the implementation process. It's just a mindset issue and resource issue to overcome these barriers. In summary, we found that, consistent with our hypothesis, that more highly activated patients were in fact reporting better PROs of social, emotional, and physical functioning. However, contrary to our hypothesis, we find no differences between practices with high adoption of patient engagement strategies and low adoption in terms of their patient-reported outcomes and their patient engagement activation levels. And we saw no differential change over time for either of these, between these two high and low groups. Similarly, we didn't find any differential changes or different point in time changes between practices with high versus low relational coordination. Some of the limitations are these are two ACOs, mostly commercially insured patients, but with substantial variation in the adoption of patient engagement activities, even though they're under the same umbrella or ACOs, they had high variation in adoption. What we were perplexed by and surprised by was how little overtime change there was in the patient-reported outcomes. And when you're doing an overtime study, you're trying to exploit the variation in change over time. And because we didn't have large change, it's hard to exploit that variation to improve causal inferences that we could make. Our survey response rates are really good, given all the incentives and follow-up that we did, but there's always a risk that differential non-response by patients could affect the results. In terms of research and policy implications, we come out of this work thinking that ACOs may need to make the investment in routinely collecting and monitoring these patient-reported outcomes of social, physical, and emotional function to ensure that these strategies that are being adopted, like motivational interviewing, shared decision-making, are actually having their intended effect on patient-reported outcomes that have high value to patients and families, rather than just focusing on the clinical biomarkers for diabetes and cardiovascular disease. And we also find that even though previous studies have suggested teamwork and relationships are really important for patient engagement, relational coordination in and of itself may be necessary but insufficient for improving patient-reported outcomes of social emotional functioning in the short run. Thanks a lot. I look forward to your questions.
Wonderful. Thank you so much, Hector. So this is a time where everybody jumps in. This is really very, very interesting and certainly piques our interest in different areas. So please unmute yourself. The mute is on the left-hand side of your screen, so you can unmute yourself to ask questions.
So I have questions for the audience. I guess one is, given that in mental health and substance abuse treatment, adherence and engagement and patient engagement are really critical to the success of clinical interventions or other interventions. Does this type of inquiry, in terms of trying to link what practices are doing to engage patients to the patient-reported outcomes, seem like something that would be feasible in your clinical context, or would it be, are there other issues, confounders, or other challenges that might make this difficult or more difficult to interpret? Or would it be easier because there's such a strong history of patient engagement strategies being used in mental health and substance abuse treatment?
Well, if I may jump in, from the behavioral health perspective, certainly engagement is one of the key goals, and that is because, of course, there's the issue of stigma, there's the issue of kind of issues of trying to increase access by improving, reducing the stigma in the client population as well as in the provider population, as well as to try to understand where the patient is at, to try to engage them with different strategies, right? And some of it is from the cultural linguistic aspect of using language, using the same language, for instance. The second is addressing cultural norms and cultural understandings of, in this case, of addiction, for instance. The other parts is the more technical pieces, which could be the motivational interviewing, cognitive restructuring, all these different techniques. But there's a great deal of interest in it, but I think your findings are consistent with what happens in behavioral health as well, where there may not be as much investment on this engagement strategies and more on the more kind of basic interactions.
Yeah, it was one thing I didn't mention in the qualitative interviews when we visited practicing primary care physicians and teams is like, I think everybody thinks they know what patient engagement is and that they're already doing it. And so I think that's one major hurdle for implementing, some of these strategies that you see up here is that we already kind of do this as part of our work. Why do we need a new system or process for this? So I think that has been one major challenge, cultural challenge in terms of, clinicians thinking that what they received in their professional training is sufficient training to do some of this, which we know that medical education is not really addressing some of these things like motivational interviewing, maybe in new curricular redesigns, but generally not historically. How about family participation programs? This is something that's getting a lot of attention in diabetes in particular. As I mentioned, adult children, there's a lot of interventions now, practices are trying with adult children because they tend to be the primary caregivers or support system for their parents. I certainly know in my role, as a child of a diabetic adult, certainly, contributing to that. But family members can also be distractions or problematic in, the patient engagement and care management process. There could be blaming or shaming or, non-productive communication, guilt, these other kinds of things that family members can bring. So I was interested in hearing potentially from you or others, now that there's only 3 of us, what, with the movement in mental health and substance abuse treatment with respect to families. So I think that's where ACOs are going in terms of chronic care management, trying to involve family members and peers and things like that more.
Yeah, I'll leave it to our other, who's on the other line? You want to jump in?
It's me,
Oh,
Tenny.
Tenny.
Yes. I was actually thinking when you were saying that, Dr. Rodriguez. So I've studied diabetes with adolescents and like treatments and all of that. And what I've noticed on the other end of the spectrum, because that's my specialty, I specialize in adolescent research, is that when the parents are involved with adolescent, treatment of diabetes, for instance, the adolescents are very hesitant because they kind of want to like be the adults in the, with their treatment process. And so there's a lot of issues and there's a lot of literature on just pretty much treatment adherence and like the long-term benefits and cons of the family being involved. So I can see it working both ways, because if an adolescent feels that their parent is being overbearing with their diabetes treatment, I can see it, of course, happening with the parents as well. If the child is in a way, like taking care of the parent that's the diabetic. So I can definitely see that happening. It's coming to the forefront a lot in the diabetes research at my campus, actually at UC Merced. So I don't know if that's linked to what you were saying, but it just made me think of that.
Yeah, one of the things that I think systems are struggling with in general is how much to pester patients, in terms of is for participation in these engagement programs, pestering them about health risk assessments, pestering them about following up on tests and stuff like that. In fact, one of the ACOs where we visited, we learned that one of their outreach strategies to get non-compliant patients back into care was called PESTER, and it was an acronym for patient, and stuff like that. And so I think there's a consciousness that, what healthcare systems do might be overburdening or overwhelming patients. So that's another side of these patient engagement programs is like, we can't throw all of this at one patient.
Exactly.
They're not going to be able to tolerate all of the demands for them to do things. So part of this patient engagement work is like, what strategy is going to work for a given patient? Are there certain things that need to be systematized and routinized for every patient? Whereas are there some that are more targeted and the like? I think overwhelming patients, especially in diabetes care, given multifaceted determinants in terms of management, like health behaviors and adherence and all of that, I think it's complicated.
Yes, no, I agree. And if I may add, I think the point in common here is, for instance, with substance use disorders and diabetes and all, is this kind of notion of chronic care conditions, right? That all of these are chronic care conditions that require kind of not only an ongoing monitoring and investment from the person affected by the chronic care condition, but also kind of a sense of support. And typically it's kind of the family support, a healthcare team, all kinds of other types of community supports. And what kind of gets to be challenging and maybe in need of tailoring is that each chronic care condition has its own program, has its own approach, has its own level of stigma. So for instance, with opioids, or with drug use, has its own level of stigma where users tend to not want others involved in their care, and it just becomes difficult.
How about peers? Peers instead of family. People have been through the same thing.
Yeah, peers have been very, very helpfully integrated in substance abuse for the longest time, and now it's becoming very or more common in mental health. Mental health has been integrating peer navigation as well as peer support, but / interventions. Now, even the Department of Mental Health in LA County are hiring peers to provide some levels of intervention that sometimes mimic what therapists do in terms of providing advice, in terms of providing some guidance, education. And that is coming out of the research that basically says that these peers have influence, right, on individuals with special severe mental health, and that have a potential to basically get greater buy-in in terms of the type of education necessarily, issues like medication management, which affects all chronic care conditions. And it's a major issue, right, for patients to adhere to medication management, as well as just navigating the healthcare system. Go to meetings, go to supportive meetings, support meetings, go to appointments, and so forth. So I think from the healthcare system perspective, I was very curious about this work, because it's very comprehensive. It's kind of one of the most comprehensive views at patient engagement that I've seen, studies at patient engagement, and kind of the mixed methods and the longitudinal aspect of it, and to find little variation across organizational practices is certainly very intriguing.
Yeah, and these are practices just to, under ACOs, I think there's a common conception that they're all homogenous. And so most ACOs are born out of integrations or mergers or, the like. And so they're an eclectic group of practice, some that had been part of a integrated organization for many decades, and others that have been independent practices that are under the wings, now newly under the wings of the ACO. And so what struck us is that we expected lots of heterogeneity, given that they have these different histories with the ACO, the individual practices. But surprisingly, we found very little. Even when we try to stratify based on different things, we found very little, nothing really differentiated practices very well, which says a lot about the common challenge that practices have with respect to the patient-reported outcomes and engaging this population. There's not like a huge footprint of a practice doing better, in other words. Yes. One of the things that was very intriguing to us, and I don't know how it squares with mental health care teams or substance abuse treatment teams, is this idea of when you try to do more patient engagement, like formally, like shared decision-making or whatever, that what we see is a natural teaming or relational improvement among those members. So when they when team members work together to engage the patient, it seems to help their relationships with one another. That's what we're seeing.
As we know, even there's very different views in terms of how to respond to patients' needs, even across teams. And if there is conflict in the team, then especially when there are hierarchies, when there are power struggles, then I could see how that conflict can really diminish the potential benefit, right? The potential effect of the team on clients' care.
Yeah. One of the things that comes to mind is that we know in the social psychological literature on social loafing, that the more that you have overlapping scope of work and practice among members of a team, the more likely social loafing is going to happen, or that people expend less energy on the team process or to the work than if they were working alone. And this is exacerbated by mental health and substance abuse treatments continuum of professions, I think, where there's a lot of overlapping scope of practice. So what one clinician can do, the other one can do. And I think when you have that situation where there's not really clearly delineated roles and separate and clearly defined and agreed upon, I think that's when you see a lot of these team problems happening. Whereas in primary care, in these kinds of teams that I'm talking about, there's no overlapping scope of practice, or there is, but it's not as drastic as in, I think, mental health or substance abuse treatment. So I would think that this potentially wouldn't work the same way in a mental health team or behavioral health team unless they had clear delineation of responsibilities and scope of practice, like at baseline.
There's some substance abuse counselors that they believe in zero tolerance for any substance. So they kind of may create a lot of tensions even in this counseling of behavioral health issues.
Yeah, more drastic conflict of recommendations. I can see that. Yeah.
Yes.
Right.
Okay. Well, Hector, thank you so much for being part of this presentation.
I welcome anybody who's viewing this at home to contact me if you have any questions. I'd be happy to talk.
Wonderful. Well, thank you again, Dr. Rodriguez.
Thank you. Take care.